Meet everyone. And thank you all for coming here. And also, again, Nova and Clarissa, thank you for this opportunity and all of NAMI Baltimore. So we're going to talk about some mental health issues and with the family. And if I can, I guess, start by saying, why do we want to talk about this issue? And that is because mental illnesses are very common in our society and are often underreported and unfortunately undertreated. And a lot of people suffer in silence. Some statistics to get us started and let you know is that about 1 in 5 adults in the United States lives with a mental illness, which is 51.5 million adults, or 20.6% of the population. So that's a lot of people. Mental illness tends to be seen with a higher prevalence rate among younger people. Young adults have the highest prevalence at 29%, and compared to adults of middle age, 26 to 49-year-olds at 25%, and then older adults seem to have the less prevalence. A couple of the statistics I want to just say too is that mental illness also starts early in life. And a lot of times children or adolescents can be misunderstood, and what are called behavior problems often can be a early sign of a mental disorder. And again, statistics again saying about 49.5% of any adolescent, so about half of all teenagers at some point in time, have a lifetime prevalence of a mental disorder, and about 22% of teenagers or adolescents show a severe impairment from their mental disorder. Another statistic and group we're going to talk about tonight is what is differentiated by serious mental illness, which is defined as a mental illness that causes significant impairment or disability to that person's functioning. And that happens in about 5% of adults. 13.1 million adults tend to have severe mental illness, which greatly impacts their ability to function. And I'm going to try to navigate this here. This is just a graph, again, kind of some of the data I was talking about. The other side of mental illness, what we're talking about tonight, is just as it's very common, it's also, unfortunately, not everyone gets treatment. Of all the adults that have mental illness, these are some statistics again, only about 23 million people, with 44% of them, got mental health services that same year. So that's less than half. Typically more females than males receive services. And interestingly, again, just as younger people have a higher prevalence, the lack of service continuity seems to be the opposite for them. Younger adults may have a higher prevalence, but only 38% of them got treatment compared to adults 26 to 49 years old versus older adults who had the highest rates of prevalence. And along racial lines, also, again, whites receive the highest percentage of services, 50%, compared to Hispanics and African Americans at about half, and Asian Americans at about half. So there's big service discrepancies, which we've been talking about. And this again is another graph of that. Another part of mental illness that's we need to look at is that mental illness can be fatal if untreated. Suicide is the second leading cause of death among young people, age 10 to 24. And it's the fourth leading cause of death for those aged 35 to 44. It's also overall the 10th leading cause of death in the United States. Last year, in 2019, 47,500 Americans died by suicide. And another statistic to look at is that 2.5 as many times Americans died by suicide than by homicide. So violence is another part of mental illness, and suicide that is something we need to look at that's causing us problems. Another aspect of behavioral health too that we're looking at, you hear in the news this, we call the heroin epidemic, an opiate epidemic here in Baltimore and around the country. Other areas that we're going to look at are the issue of addiction and substance use. And I wanted to break this down into and to differentiate that there are these are both medical conditions, and the term addiction is often not really used in psychiatric parlance per se. We use the term substance use disorder, but the official definition of an addiction by the American Society of Addiction Medicine, known as ASAM, is basically looking at a disease of the inability to abstain from a substance or a behavior, a pattern of a brain reward in the brain imbalance and dysfunction in those areas. So bringing all that together and make it simple for you, an addiction is, physically changes the brain when someone has addiction. And what's rewarded to most people that don't have an addiction, like getting up in the morning and having food on the table and taking care of yourself. When you're in addiction, that part of the brain is not what's your primary focus. It's maintaining the substance or the behavioral of the addiction. Another thing that we want to talk about is treatment for all of this. And on the right-hand side of this page, I wanted just to look at this for a minute, is there are 6 dimensions to diagnosing and treating an addiction. And these dimensions are listed there on the right-hand side. But I wanted just to point out and say that, again, one thing we're going to look at is treatment is just not one-sided or one thing or one magic pill or one magic, therapist. It's, multidimensional. It's biological, psychological, spiritual, and social. And that's kind of what's involved here. You can see as it goes down the list, they look at the biomedical conditions, emotional, behavioral conditions, etc. Substance use is very common, again, in the United States. And these are just some, again, typical, the official ways to diagnose a substance use problem. If you see these behaviors in yourself or your loved one, we kind of can read this over, and if you can check off, start checking them off, that's a sign that, probably you do have a issue with substances. The first one could be taking a substance in larger amounts or for longer periods of time. A desire to decrease or control your substance use, and not being able to, spending a great deal of time obtaining a substance, using it, or recovering from its effect. Strong desire to continue using the substance, and continued use resulting in, inability to fulfill your responsibilities. So typically the way that we diagnose this is if someone has, we characterize it as mild, moderate, or severe. A severe substance use the individual would have between 7 or more of these. A moderate substance use would be 5 to 6, and mild would be, I believe, 3 to 4. But those are the things that we look at. And again, just looking at, some statistics on substance use. You can see at the top when we talk about it, alcohol is the most widely abused substance in the United States among people age 12 or older, followed by tobacco, which we don't think of much, but that's certainly a substance, marijuana, and then going down through different various illicit drugs. In the past month, from this was from 2018, 60.2% of the population in the past month reported using one of these or more of these substances. So that's very common, a very high percentage, and again, of what we're looking at and treating. Some more statistics, and then I'll wrap this up, is, as we were saying, about 20.3 million Americans age 12 or older, which is 6.2% of the population. Let me go back for a minute, had a substance use disorder. This big percentage here of where they're talking about the 168 million people, we're excluding the tobacco population. When we talk about substance use disorders, we're diagnosing pretty much everything else on here except for the tobacco. That is not considered an illicit substance. So when I talk about substance use, I'm talking about alcohol or illicit drugs, which would include the other things. But in 2018, as I said, about 20.3 million individuals had a problem with the use of alcohol or illicit drugs. As we said, alcohol being the most common and illicit drugs being about 8.1 million people. Another statistic that you look at a lot, we hear a lot, is that both individuals can have both a psychiatric or mental illness and a substance use problem. And that occurred in about 9.2 million of adults, and 3.2 million adults had a serious mental illness and a substance use disorder co-occurring together. You take all this together, and again, I would just want you to focus on this bottom number here. Of the 21.2 million people who need treatment for substance use, only 3.7 million people, or 17%, received any treatment. So substance use is very common, but not everyone gets treatment. There's a lot of reasons for that. Some people have trouble accepting the need for treatment and may not accept treatment. Many other people have social, financial issues that prevent them from getting treatment. But the gaps in treatment is a big issue that I want us to look at. Back to, as I said, in Maryland, we are lucky, I will say. I've worked in other places, but Maryland has a very active and strong public behavioral health system. And the public behavioral health system differentiates and has targets of different populations. What they call a priority population diagnosis is kind of what I was referring to as serious mental illness. This would include individuals with schizophrenia, schizoaffective disorder, and so on, bipolar 1, bipolar 2, major depressive disorder, and borderline personality and other specified schizophrenia spectrum disorders. Those are the target groups of the psychosocial services that this public behavioral health system is looking at. So what treatment is available for all of this? Well, I wanted to talk about tonight a couple of the, obviously here at the hospital, we offer pretty much a whole wide continuum of services. And we work very closely, I'm glad to say, with the public behavioral health system, especially in Baltimore City. There are many resources available. To just start with some of the types of names and things you might hear. Outpatient treatment, which this is available here at the clinic, at the hospital. We offer outpatient treatment, which is kind of your classic individual family psychotherapy and medication management with a psychiatrist. And outpatient treatment is usually defined as like at least 1 or 2 hours a week. We also offer what's called intensive outpatient, or IOP. Those are therapeutic and medication services with me and Dr. K and the other staff. And the patients will come for 9 to 19 hours a week, about 3 to 4 days a week. And we have another type of treatment, PHP, which is a little bit more. It's, again, patients can come 20 hours at least or more a week. We do a lot of services on telehealth right now because of COVID. But we do see a lot of people, and these are all, again, outpatient-based services, meaning a person can be at home or in the community, come for treatment, get their medicine, get the therapy, and then go on back about their life and have some independence. If someone's illness is getting more severe or needs higher level of care, we have obviously a locked inpatient unit, which, inpatient care is, in the hospital, 24-hour nursing care with a psychiatrist. And we have, for individuals in crisis in the emergency room, what's kind of commonly called the Psych ED, Psych Emergency Department, or CIS. Those are services available here. I wanted just to real quick talk about what's available through the public behavioral health system. A service called, you might have heard, PRP, or psychiatric rehabilitation, is kind of for individuals, again, with serious mental illness that need the rehabilitation. They need to learn how to budget money, live independently, obtain a job, interact with their family, or maintain their community living. PRP is an excellent type of service that meets regularly and ongoing for those individuals. Other services that we can refer to are what's sometimes called the ACT team, or mobile treatment, which is for individuals that are homeless or at risk of homelessness, And the treatment is just that, it's mobile, it comes to you, it comes to the patient. So individuals that have a hard time getting to a doctor's office for whatever reason, or have a difficulty accepting the need for treatment, we can refer you to mobile treatment also is available. Other services that we often refer with are called RRP, which is a residential rehab program. And I tell people it's kind of like what you would think of as like a group home or assisted living. If someone's unable to live in the community independently, there are houses and programs that we work very closely with to refer you into. And obviously case management services, or targeted case management services to help someone, sometimes people just getting out of jail or prison or homeless, obviously are going to need a lot of services to get themselves going. And, things we take for granted, like being able to drive to your doctor's office or, have a place to stay, they need someone to help them get to a doctor's office or get an ID card. That's some services that you can get. And then another type of service that I want to just say that we also refer people to is what's called residential crisis. And residential crisis is often, is kind of like, I often tell people, we can use that in lieu of going to the hospital for inpatient, for someone whose illness has gotten very severe and they need intensive help in a residential setting, but maybe they don't want to go to the hospital or the hospital's scary to them. We can refer them to one of these residential crisis programs. And those generally last about 10 days or so, but it often helps keep people in the community and not have to go inpatient. So that was a quick overview, real quick, of what we have to offer. I'm going to pass the baton over to my colleague and friend, Dr. Kankam, to tell you a little bit more about mental health.
Okay, thanks, James. That was a good overview of that, of what we have available. And thank you all for joining. And I hope you join in with some of your young ones, because as James said, the devastation of mental illnesses don't spare the young people. So I'm hoping that they're around you. And like he also said, that a lot of the illnesses, the onset is in early years, but there's still a huge gap between onset and presenting for services, if they do at all. Now, there are many reasons that happens. Stigma is one, and we know that it's still alive and strong in many forms. Socioeconomic challenges, but tonight we want to focus on one key factor, the fact that people still misunderstand what even our normal mental health is, and the illnesses and the flags that indicate that there might be an illness. So what I want to do is focus first on the normal mental health, and then we can talk about the illnesses. Now, I find it's with my patients and other people, comparing what we all know, the so-called physical illnesses or physical health, that helps. So, what is our mental health? Our mental health is one of about a dozen of the body's health systems. We are familiar with, I put down about 3 of them, are cardiovascular. Everybody knows that. The respiratory, I think there's nobody who hasn't heard about that in the last 18 months, about the respiratory system because of the COVID-19. And we know that it is vital to our survival. Now we have another one that I put on is musculoskeletal, the muscles and bones. Now, we don't need that to live, but without that, we can be alive but immobile. So every health system has a specific role it plays, okay? Now, it's helpful once we know in all the 3 that I talked about, because we know the role it plays. If I'm short of breath, I'm worried that it might be my lungs, and I know that the respiratory system gets the oxygen into the body. So I call my doctor. The same thing. If we have chest tightness or a heart is beating fast, because it's common knowledge, we get help. So what about the mental health system? So this originates from the brain. And to explain it, I'm going to contrast it with another system in the brain, which people are more familiar with, the intellectual system. That's what allows learning. So most parents know the milestones that their children have to be, when you point, when you can say words, how many, and if they don't get to that milestone, they are their pediatrician because they are aware of it. Okay. Now, so the intellectual system gets us learning and knowledge. But we all agree that knowledge alone won't get us far in the world. Okay. So mental health system, what does it do? That's the system, and I'm going to, okay. Okay, so the mental health system, this is a task. It keeps us content. Content doesn't mean there are no problems, but we still keeps us, put it in the center. It helps us adapt situations, relate to others appropriately, and be able to use our intellectual abilities to contribute to the community, whether we're working, we're in school, we are part of a community. This is the work of the mental health system. And it does that with assessing and influencing our decision-making. So keep that in mind, because when it's not working, when it goes from health into illness, these are what it impacts. Now, how does it do that? Well, it does that by the concept of these core value systems. So the intellectual abilities are almost like predetermined. We know when a child does all these milestones. However, the mental health system is not developed in childhood. We have these 4 basic core systems, core belief systems, fear, resentment, optimism, or pessimism. Now, these 4 create their own thoughts. There are thoughts, by the time a child is growing, there are many thoughts that they have created in their mind. And these thoughts are generated, or I call it filters. They can be grouped into these 4. But a child hasn't grown, hasn't experienced the world. So they are not equipped to group them. And so we rely heavily on the adults in our lives as children to associate different situations with these. And what it already shows is that we can be intentional about what we associate with our child's value system. What you determine is fear. And it's not just by saying you have to fear this. It's what the child sees, hears, experiences. And by the time that they're adults, we go to maturity, it's almost like the template, And that's also why 2 people can experience the same situations and they will not experience it the same because they have been brought up differently. I call them man filters, okay? So these, and I got this from an advert. Imagine that you have these lenses, not on our eyes, but in our brain, okay? So that whatever we see, whatever we hear, we are not seeing with our eyes, we're seeing with our mind's eyes, as they say, So how does it work? Each of these, now, Okay, so imagine that this is our brain, this is our mind, and each of these, optimism, disgust, which is resentment, fear, and pessimism, they create thoughts. When we say our head talk, they create thoughts that are consistent with each value system. So the optimistic value system is the one that gives us hope, okay? The disgust is almost like a challenge to a dignity, okay? And it creates resentment. Fear is fear, danger to avoid, okay? And pessimism is like the opposite of the optimism. The mindset or the mind talk is about regrets and shame and embarrassment. Now, these are still normal, even though it's distressing, they are still normal because of these, we produce our core life skills. Being optimistic gives us self-esteem. It gives us the courage to explore, to take risk. Even in terms of the indignancy, it allows you to be assertive so that people don't walk over us, okay? Fear gives us caution, and pessimism allows us to be empathic. In the normal mental health system, when it's functioning, they are all working together. So that's one, okay? They view situations together. And remember, the goal is to protect us. So for example, I give an example, you crossing the street, you see your friend, you're hopeful, I want to see my friend. You hear the voice of caution. There's a car passing by. It might, so you already have associated car going fast with danger. So you hear the voice of caution. And rather than leave, it's like they are talking. I tell people they are communing among each other. So you can wait, car passes, you leave. So this continues all day long. This is in our background going on all the time. Now, from these two, do we have the core life skills, okay, which, like I said, being ambitious, being, resentful, even though it's resentful, the life, one of the, not being walked over is also a skill. Being cautious is a skill. Some of the employers call these the soft skills. In addition to your intellectual achievement, these soft skills are also desirable. So they are normal. How do they express themselves? Nobody can hear our thoughts. So all this is silent talk. Each one expresses itself in feeling, one word feeling. Sometimes people say, I feel like I'm going, feeling is one. You're sad, you're anxious, you're angry, or you're happy. What is also sometimes not appreciated, it's not just about feeling. It is also expressed in physical patterns. Some internal, like a heartbeat, sweating, pupil dilatation, saliva in our mouth. These are responses to some of them, especially the fear, the anxious line. They respond, they express themselves a lot in internal muscle, the muscles of the internal organs. So the person who is anxious may feel palpitations, may be sweating. Then it could be overt, like their facial expressions or a sleep pattern. Now, both these physical symptoms or physical patterns are also learned, or they are heavily influenced by our childhood interactions. Now, what's important even right now to note is that you can see my thoughts, you can see my feeling, and a large part of the physical expressions you can see. So the first thing is, we don't expect to see someone's emotions. Unfortunately, that happens a lot. I think you are thinking this. I think this person is thinking this. They are doing this because of this, and that's half of the world's problems. So our emotions are our thoughts, our feelings, and the physical expression. And when it's working normally, they are working together. That's one. Secondly, these thoughts, each of these thoughts have a specific pattern. There should be just the right quantity of thoughts at a given time, the right speed, orderly. And when it goes wrong, as we see, those are the levels at which there are changes. So that's what alerts you that there may be a medical condition going on. And each of these lines can produce changes that is the signal that something may go wrong. Just like we can have, using an example of physical, quote unquote, if you are short of breath, you know that it's probably my breathing, something is wrong with my breathing. How you know for each of them is, some of them, we call them episodes. There may be changes in which instead of all of them working collaboratively, one becomes magnified. So if, say, this line, the pessimistic line, is the only one talking, or it's magnified at the expense of, say, the optimistic, then you keep hearing. When you view things, you only see the pessimistic side, the gloom and doom, and you're not hearing the voice of hope. Of course, the mood only reflects what is in the thought. So at that point, your sadness is more than what you are used to. We're always comparing with changes from our usual, not comparing two people. Everybody knows their pattern. And then the physical expressions get magnified, okay? In the case of pessimism, it is what eventually, when you can see hope, you know, people might say, oh, but can't you see, you know, everything is happening. Why they can't see it? Like someone said, there was love around me, I couldn't feel it. So, and these are one's true beliefs. So there's the important thing is only us can tell the first signs of something going wrong. Now, there are times that we are sad and we should be sad about something, or anxious. All these are normal. However, in normal, it doesn't go too far out before it comes back to the center, okay? In abnormal states, so each set of changes we call an episode of changes. So you can have an episode of sad changes, episode of anxious, episode of anger, an episode of happy. Two things that have to meet the criteria to say you have an episode. Of course, one is it's magnified. This is intense, but it has to be persistent. It can't be just a day or two. A day or two is the normal. We get sad about things. But if it's persistent, almost every day for a couple of weeks, okay, that's one, and then impacts those things that I talked about, that the mental health helps, your own peace of mind, or not being able to interact the way you interact or function, then we say you have a bout or an episode of that line of mood. We usually use the moods when we should be using the thinking. So you have a line of episode of depression. So you can have an episode of depression, you can have an episode of anxiety, an episode of anger and excitement, except we have a different name we call these two. We call them episode of mania. Okay, there is so much that goes on. Mania is used in derogatory manner, but it's a medical condition. Okay, so each episode now, just like if you have a cough or shortness of breath, you're not the one making the diagnosis, but it's what alerts you that I need to get a checkup. So the take-home message here is, it's you who are going to know that these set of changes that is gone on for a while and it's affecting your life, you need to have a medical checkup. You can call, like James told us, there are services, you can talk to any healthcare person. However, what is important is to know what to say. And that's one of the issues in diagnosis. When, let's say you decide you have got the red flag, you've decided that I think there's something going on, let me call someone. You call a doctor. The same way that if I call my doctor and I'm coughing, short of breath, I want the doctor to get the right diagnosis. So I'm going to give all the information that I can get. Now, in many of the other physical illnesses, they have the labs, they have the X-ray. Mental health, we don't have any of that. What we do have is to put the puzzle together. And who has the puzzle but the person who is doing the thinking, the feeling, and the physical changes. That's why it's important that I focus on this, because the information we give and what is explored from them, that's what determines what the illness is, because an episode is not the illness. An episode of coughing and shortness of breath is not the illness. It's for the doctor to determine, do you have pneumonia? Do you have this? Do you have the others? The same way, every episode, okay, tells us there's an illness. And how do we determine? I'm going to tell how the doctor would determine, and I'm still going to say it on this slide. Let's say you see the doctor and they determine that, yes, you have an episode of depression. How do you tell the illness? Okay. Determining the illness when you have an episode of depression is the more challenging of the two. Anxiety is easy, because anxiety, you have an episode of anxiety, you have an anxiety disorder, and there are various types, but that's what I want to focus on, is how you determine when it is depression. When it's depression, if you have never, ever had any of these two episodes ever in your life, then this depression episode is an illness called major depressive disorder. If you have ever in your life, whether it was treated or not, had any of these two, then that illness is called bipolar disorder. And okay. Okay. So, and I fast forwarded to the depression because the anxiety is the easiest to diagnose. Okay. But the depression is what we struggle with. Since you want an opportunity for accurate diagnosis, I advise you, if you have ever had, whether we ask you or not, tell us. Some time ago, I went through a change where I was agitated, or I was overly excited, and I was doing impulsive things. Those two are not distressful. So we may not recognize it, but other people may tell us things, and it's important because that's how we get to know. So these two illnesses are treated differently. So okay, so let's see, say you see a doctor in this episode. You've never had any other episode episode of anger or excitement, which will indicate that you had mania ever. This illness would be major depressive disorder. It's treated one way. Let's say you came back to the doctor a couple of months later, here or here. In between, you have experienced the episode that we call mania. This illness is different. This illness is called bipolar disorder, and you're experiencing the depression aspect of it. They are treated differently. And sometimes we get it wrong. So please, if you have ever experienced it, you want to let the doctor know. I can't say enough of that. Okay, now other things that come up in treatment, okay, what we call psychosis. Psychosis, while I talked about the views as magnified, in psychosis, it's like it's distorted. So the things we hear, see, feel may be distorted, and people talk about hearing voices, seeing things, smelling things that are not real, or believing things that other people don't believe. And again, it's a change for that person. I bring it up because in the past, if somebody experienced psychosis, it's assumed that they have the collection, the group of illnesses that James talked about, the schizophrenic group of illnesses. But every episode that we have, every mood episode, if it's severe, you can experience psychosis. And again, it's important to let the doctor know. James talked about substance use. The reason I bring it up here is both for us and for the person who is coming to treatment. Sometimes people are self-medicating. Sometimes we detected the depression, bipolar disorder, we're treating, but we haven't detected that they may have anxiety disorder. They're using the alcohol to treat. And it's important. I ask every patient, what does this do for you? And so it can alert us to other illnesses that we haven't detected. So that's important to bring up. It's no shame to bring it up. Lastly, suicide. We never do an evaluation without asking about suicide. In the past, it felt like, don't ask, don't tell. Don't talk about suicide, you might put it in someone's mind. We now know that, especially in the episode of depression, as you have more gloom and doom and can't hear the voice of hope, at some point the mind is so overwhelmed that they want to get out of the pain. And the way to get out of the pain, the mind thinks, is getting themselves out. And so the mind produces suicide thoughts. And it's good to ask, so we know that it may happen. There are certain factors that increase the risk of acting on it. Previous attempts, having depression episode that is not treated, access to lethal means. If someone close to you has completed suicide, isolation, not only do we look for risk, we also look for protective factors because there are things that can protect. Having social support system is one. Having pre-existing good coping skills. Having beliefs. Some people have said, I would have done it, but my religion forbids me, I won't go to heaven. And we encourage that too. So these are all the things during evaluation that is important. Again, is the doctor or counselor or healthcare provider who is going to make the diagnosis. But what I want to stress is a lot depends on us, because most of the information needed to make a diagnosis rests with us. So I'm not going to go over specific treatment, just as to say, in terms of medication is like, people ask, sometimes people will say, oh, but the drug, but it might go to my head, especially when they're taking their children. Every drug for diabetes, hypertension, Tylenol, whatever we take, still goes through the bloodstream and goes through our brain. So every medication has been judged to be safe, and that's why I use it. The pity of mental health is that in the last 3 decades, there have been improvement and more available treatments. Unfortunately, people are not getting to it. So if one medication is not agreeing with you or it's not working, there are others. Sometimes people come and they say, my friend used this or my friend did. Everybody's system is different. So I have 10 questions to ask your doctor. You want to be empowered in your treatment. You do that with other illnesses. The person who is being treated for high blood pressure, diabetes, you are screening, you are taking your blood pressure, you're taking your blood, and you are a part of the treatment. That should be the same way for being in mental health treatment. What is my illness? Ask us to explain. Don't just settle for lingo. What is this? How does it explain your symptoms now and your past symptoms? What should you expect? Is the treatment going to get the illness gone and never come back? It's a good question to ask. Most of the illnesses are like your diabetes and your asthma. They come and go. And other questions here, what can I not mix with my medication? So my time is up, and probably I'm sure there will be more questions similar to this. And so I will stop here, and then I hope that we have an active discussion. Thank you.
All right, thank you for that, Dr. Kankam. I want to start off with some questions. This first question is kind of directed to both James and Dr. Kankam. Someone asked, what treatment modality would be recommended for a 27-year-old individual that is suffering from a social phobia that is preventing them from leaving the home, working, interacting, etc.?